I am going to touch upon the role of inflammation as a novel target in the cardiovascular disease, namely the atherosclerotic arterial disease. The Rudolf Virchow, the mid-19th century, he described inflammation as the basis for the arterial changes, and that is the mechanism for the primary importance of arteriogenesis. Atherosclerosis starts from very young to old, and arterial thrombosis is the leading cause of death worldwide. The manifestation may be from top to bottom, starting from the middle, from the heart. It may be presenting as angina, either stable or unstable, or it may be an acute coronary syndrome of STEMI or non-STEMI. Or in the brain, it may cause PAA or an ischemic stroke. In the periphery, it will cause a peripheral arterial disease with the rest of claudication pain leading on to gangrene. Now, the theory of atherosclerosis goes like this. The common culprits are dyslipidemias, resulting in endothelial dysfunction, and there is free radicals and immunology. This, in turn, are provoking the so-called inflammation, which is the basis for the atherosclerotic arterial disease. And we know the classical risk factors like hypertension, diabetes mellitus, smoking, and hyperlipidemia. In addition, the oxidative stress species and the possibility of infection, either bacterial or viral, which will result in endothelial dysfunction, and it will provoke the inflammatory process, leading on to acute phase response of the systemic inflammatory response. And that is being manifested as the form of elevated CRP, which is not only a biomarker but is also the culprit to provoke a lot of havoc at the endothelial and subendothelial region, resulting in finally the atherosclerotic process. So atherosclerosis is a fibroproliferative and inflammatory process occurring in response to a variety of vascular insults. We know the classical risk factors, and there are novel risk factors that are also well aware, resulting in endothelial dysfunction. And there is modulation of the endothelial dysfunction, which will be the target. Thereby we can either prevent or retard the atherosclerotic process. Apart from the classical risk factors, namely the diabetes mellitus, lipids, hypertension, and thrombotic episodes, these four are more talked about in the recent past, namely the behavior aspect of the person concerned and the genetic predisposition. Apart from that, inflammatory process is the basis. And it is well known, at least in 60% of the patients of atherosclerotic arterial disease, the classical risk factors are not present, either as one or not even a single traditional or classical risk factors. And not only that, at least in Indian scenario, the hyperlipidemia is not so marked as in Western setup. Then, even then, with this limited risk factors and limited elevation of lipids, we are more prone for coronary atherosclerotic arterial disease. The reason being our genetic predisposition, number one. Number two, our diet habits. And it has been proved beyond doubt that more than the LDL, it is the CRP, C-reactive protein, that is very significant, and that is going to tell the fortune or misfortune of the patient concerned. CRP is not only a marker, but it has got a major role in the process of atherosclerosis. To solve it, it enhances the uptake of LDL, and it also blends the endothelial vasoreactivity, and it induces the tissue factor in monocytes, and it causes complement activation. It reduces the nitric oxide production from the endothelium, and it increases the PAI1, and it triggers the oxidation of the LDL cholesterol. All these steps are involved in the process of atherosclerosis. That's what's given here. On one side, it is causing LDL. See, normally the endothelium repels the cells as well as the LDL cholesterol. That's very, very important. By some insult to the endothelium, vascular endothelium, there is a chance of addition of the cells, mainly the monocytes, the T cells as well as the mast cells on the one side. On the other side, there is entry of lipid core in the form of LDL cholesterol, especially small dense LDL cholesterol, which is very common with the diabetic population. And they all will result in atherosclerotic process, resulting in clot, vulnerability for the clot to get ruptured. The 2013 guideline says use of high sensitivity CRP. See, the normal CRP is getting increased whenever there is an inflammatory process by 1,000 folds, and we are not able to fix up the range, the normal range, up to which it is normal, and beyond that it is abnormal when you measure an ordinary CRP. See, instead of that, we are going to measure the highly sensitive or high sensitive CRP, which has got its own range that I will touch upon later. And the 2013 guideline says that the use of HSCRP for stratifying the high risk of patients for atherosclerotic cardiovascular disease. So this is what I was telling. See, the normal range is it is usually less than 1 milligram per liter, up to 3 milligrams, from 1 to 3 milligrams HSCRP. I am talking about the HSCRP. It is having a moderate risk as far as the atherosclerotic process is concerned. When it is beyond 10 milligrams per liter, don't think in terms of the coronary risk or atherosclerotic risk. Think in terms of some acute phase reaction happening due to some inflammation somewhere in the body. So in such cases, if you come across patients having HSCRP more than 10 milligrams per liter, ignore that. Wait for 4 weeks and repeat. By the time the acute phase response could have been knocked off. Then, if it is still elevated, then it indicates the future atherosclerotic events, either coronary or cerebral. And it has been observed beyond doubt that the relative risk is getting increased when you add HSCRP with the total cholesterol as well as the HDL minus cholesterol. This is one of the picture depicting the involvement of the mononuclear cells, that is the monocytes. This is the involvement of the T lymphocytes. This is the involvement of the mast cells. I will touch upon that all together. As a result, what will happen, there is the so-called foam cell formation, and that is the beginning of the story of atherosclerosis, that will spill over the lipid core inside from it to form a lipid core, and there is post-muscle proliferation, and fibrous cap is formed. Thereby, atheromatous block is formed. This is very simple depiction of the process. See, normally the endothelium is repelling the cells. Whenever there is an insult to the endothelium causing endothelial dysfunction, there are some adjacent molecules and chemokines that make the endothelium to get attracted by the cells that are moving in the blood. So some of the cells, namely the monocytes, mast cells as well as T lymphocytes, they get attracted towards the dysfunctioning endothelium, and that is what is depicted in the picture. On the other side, the LDL cholesterol, mainly the small dense LDL, which has got more or less 20 times more affinity towards the endothelium compared with the ordinary LDL. And that the LDL gets oxidized. This oxidized LDL is very, very dangerous. That is going to be taken up by the monocyte, which is going to be the macrophage, and that is going to form the so-called foam cell. That is the beginning of the story of atherosclerosis. On the other side, it is going to act on the dendritic cells, that is T lymphocytes. And there are two important pathways that is very important to note. Namely, the nuclear factor light chain kappa induced beta cell pathway, and another one is kynurenine pathway. These are the newer pathways identified. And the other side, the inflammatory mediators are not released from the foam cells, and the platelets are getting adhered and activated and aggregated. The inflammatory mediators, they in turn activate the adjacent molecules. As a result, the endothelium is now more adhesive to the cells. So the cycle becomes vicious. As a result, more and more monocytes, more and more mast cells, and more T lymphocytes, they get adhered to the endothelium and come imbibe across the endothelium to the subendothelial region and cause havoc. Now, what best we can do to return all this process? See, one wonderful drug is the statin, an anti-inflammatory, and it is useful as a primary preventive agent by our good recognized Jupiter trial. It is proved beyond doubt, even patients with the normal LDL. But if the CRP is elevated, then they will definitely be benefited by the statin. That's one thing. Next one is this macrophage, the foam cell. This pathway, NFKB pathway, will be knocked off by PPAR gamma. That is an antidiabetic drug. That is thiazolidinediones, like our pioglitazone. And another one is the platelets. We know pretty well that the antiplatelets are very useful aspirin as a primary preventive agent. Then comes the TNF alpha inhibitors. What else? These two new pathways can be knocked off. One is by anti-inflammatory drug, namely curcumin. That is a venture by Cadila. And another one is 3-HAA anti-inflammatory metabolites. That is proved beyond doubt that it is going to be the product of kynurenine pathway. This is what is called the 3-hydroxyanthranilic acid pathway. I will tell you. This NF, nuclear factor kappa beta cell activator pathway, is not only present in atherosclerosis, but also in many of the inflammatory processes, namely rheumatoid arthritis, and asthma, inflammatory bowel disease, and also in gastritis. Not only that, it involves a lot of enzymes and adjacent molecules and receptors. So, the inflammation on one side causes havoc, resulting in the autonomic stable clock become unstable, and there is the thick fibrous cap becomes a thin fibrous cap, and that is vulnerable for rupture, and resulting in either ulceration or rupture, resulting in acute coronary syndrome in coronary artery disease. This is the autonomous plaque formation. The plaque becomes stabilized with a thick fibrous cap. When the fibrous cap becomes thin and there is more necrotic core with more lipids in that necrotic core, then this becomes a vulnerable plaque that may get ruptured, and there will be a hemorrhage at the breech site, resulting in a huge thrombus occurring in the cold vessel, resulting in acute coronary syndrome, which is the coronary atherosclerotic process. This is the pathology, the formation of the atheromatous plaque, and this is stable plaque. You can see the thickness. This is the lumen of the vessel. This atheromatous plaque, and see the thick fibrous cap, and more amount of macrophages and less amount of T cells. In due course, what will happen? The thick fibrous cap becomes thin. The new terminology is thin fibrous cap atheroma, TCFK, and that is vulnerable for rupture with the hemorrhages resulting in acute coronary syndrome if it is in the coronary process. So the current management is aiming at the accepted targets, namely the controlling the inflammatory process by statins and AC and AR inhibitors, antiplatelets, namely the aspirin, and the thiazolidine, the NKF pathway control, and TNF inhibitor. So also inhibitors of CRP and the interleukin 6. The new venture is small dose of methotrexate. Apart from these two novel targets are now looked for to attack to retard the atherosclerotic process, namely the anti-inflammatory metabolites of 3-HAA and nucleic factor kappa beta cell activation anti-inflammatory drug, namely curcumin. This is a tryptophan pathway, the kinase pathway I told for the dendritic cells, and that will result in 3-HAA, and that is an anti-inflammatory one. And it is proved beyond doubt that it is capable of reducing the lipids, especially the VLDL, and increases the HDL. Not only that, it reduces the inflammatory process and reduces the atherosclerotic process. So it is clinically useful in inhibiting the atheromatosis lesions. It is beneficial in reducing the lipids, namely the VLDL, and increase the HDL level, and it reduces the vascular inflammation, thereby making the atheromatosis clot stable. This is the NF-kB pathway that causes inflammation, activation of IKB and activation of NF-kB, resulting in release of inflammatory mediators. When you use the curcumin is from turmeric, manjal. That agent is capable of reducing the inflammation by knocking off this pathway. So this is the drug tried for reducing the atheromatosis process because it is capable of reducing the CRP, and it decreases the incidence of myocardial infarction after the CABG procedure, and it significantly reduces the serum cholesterol. It improves the left ventricular diastolic function, and of course it retards the progression of diabetic nephropathy. Apart from that, it has got a novel action in reducing the blood glucose level. There are novel promises towards retarding the atheromatosis process. One such one is controlling the IL-6 by means of the cyclosporine as well as by cortisone. And small dose of methotrexate is tried in TETIS trial and SIP trial and found to be useful in reducing or retarding the atheromatosis process. So to conclude, at least in Indian scenario, 60% of population with the atherosclerotic process with the events may not have classical or traditional risk factors, or they may have only one risk factor. And the lipid profile is not so much elevated as in breast cancer. So, what is the problem? The problem is the vulnerability for inflammation and genetic predisposition. So, we aim at controlling the inflammation by newer agents. One such one is curcumin. That is a product of Tedila. Thank you.